Hi guys, this is Dr. T Nofingana speaking. This is our very first video on my channel with the handle Dr. Medical Concepts with Dr. T. T is my name, so you're more than welcome to call me Dr. T. Okay, just briefly about me. I'm a second year medical intern. I graduated from the University of Pretoria. This is my second year of internship, and I'm currently working in the Eastern Cape, the beautiful Eastern Cape. I'm in a hospital called the Nelson Mandela Academic Hospital, and currently I'm doing family medicine, and I'm working in a emergency department at the moment. So yeah, why the channel? Since last year, you know, as an intern, as you rotate, you're gonna meet students in the departments that you'll be rotating in. And since last year, they've been asking me to make videos and even open a channel just for them, so that they can continue to get the small teachings that I would share with them, the small information that I would share with them. So I decided to eventually give in and start this channel. So yeah, one thing about me, I'm very passionate about teaching. I love teaching. So I hope you enjoy the channel, and this channel is for medical students, interns, nursing students, nurses, clinical associate students, and those that have qualified, and anyone who thinks that the content is helpful is more than welcome. And please subscribe and hit that notification bell, so that whenever I upload a video, you will get a notification. In this channel, I'm gonna cover a lot of different topics across most of the rotations that we do at medical school or in medical school. So we'll do peds, we'll do psychiatry, we'll do surgery, we're gonna do internal medicine, obs and gynae, those. So today's topic is from internal medicine, which is my passion, by the way. So today we're gonna be talking. Actually, I've had this what I'm gonna be sharing with you now. I've had it a couple of times with the students. So it's my kind of an approach to remembering antihypertensives, like in one page. So I came up with this when I was doing final year. I came up with this way of remembering antihypertensives, and it's been working for me. It worked for me, and it's been working for me even now. So let's get to it. So we all know that from physiology, BP is equals to cardiac output multiplied by peripheral resistance. And this is a mathematical formula. We know that if you increase this, this will increase. If you increase this, this will increase. If you decrease, this will decrease. If you decrease this, this will also decrease. So with hypertension, this is the problem. With hypertension, this is the problem. The BP is high. It's chronically high, or it's persistently high. So in order to decrease this, you need to play around these two. So, but physiology has also taught us that cardiac output is stroke volume multiplied by heart rate. Stroke volume times heart rate. And we also remember that cardiac output is the amount of blood that is ejected by the heart per minute, and stroke volume is the amount of blood that is ejected per beat. So And we also know that stroke volume is dependent on preload, contractility, and also afterload. So if there's any of you that is maybe lost at this point, I would advise you to go and revise your physiology in terms of physiology of the heart, the pumping mechanism of the heart, and not really the electronics of the heart or the electricity of the heart, but this portion. It shouldn't take you long. So if you increase preload, stroke volume increases, cardiac output increases, BP also increases. If you decrease this guy or this guy or this guy, this will decrease and decrease. Then you can manage your patient. But we also know that, so what is a preload? A preload, simply put, a preload is the amount of blood that makes it to the heart, that makes it from the limbs to the heart through the inferior vena cava. So the preload is mainly dependent on blood volume. Is mainly dependent on blood volume. Yes, if you've got an obstructive lesion in the inferior vena cava, then the volume of blood that makes it to the heart will be decreased. Or if you've got any condition that maybe decreases the lumen of the inferior vena cava, then you will have a decreased volume that makes it back to the heart. So you'll have a low preload. So I want to understand this. I want you to just know that blood volume, when you think about blood volume, just think about preload. Ne? So while we are still at it, so now what are the drugs that we can use to decrease blood volume? So the blood that we can use to decrease blood volume are your diuretics. Let's get a black one. So the drugs that we can use here are diuretics. So these are the drugs that we can use to decrease our blood volume, since we know that if we decrease our blood volume, we will decrease our preload and decrease our stroke volume, and then decrease our cardiac output, and eventually decrease our blood pressure. So there are 3 classes of drugs under the diuretics that we can use. We can use the loop diuretics, we can use the thiazide, and we can also use the potassium sparing. So these are loop diuretics, thiazide diuretics, potassium sparing diuretics. So what are the drugs that we find under each? Here you find furosemide. And I'll try by all means to use generic names, but a trade name for furosemide is Lasix. And then thiazide, the drugs that you find there is your HCTZ or your hydrochlorothiazide. And another one that is also common is indapamide. And the potassium sparing, the only one that I know is aldactone. Also known as spironolactone. So those are your diuretics. So if you give your patient these drugs, you will decrease. So what you want to do is you want to decrease their blood pressure, but you understand that when you decrease their blood volume, their blood pressure will decrease. So there are patients that you will put on this drug, and then that will be sufficient. So let's move on to contractility. Contractility is is the forcefulness, the strength or the power at which the cardiomyocytes contract. So if they contract very strongly, then you will have a high cardiac output. But if they contract like maybe floppy, then you will have a decreased cardiac output. So what you want to do here, you want to decrease the cardiac output, so you will make them a bit floppy. So the drugs that we use there are your calcium channel blockers. And examples of drugs that you find there, the most common ones is nifedipine, or also known as Adalat, and also there is amlodipine, also known as amlodipine. And then now let's move on to afterload. Afterload, what is afterload? Afterload is the work that the heart needs to, it's the amount of resistance that the heart has to overcome in order to have a good ejection fraction, in order to have a good cardiac output. So as the heart is pumping, so if there's a high peripheral resistance, if there's high peripheral resistance against so basically afterload is all about the amount of work the heart needs to put up in order to be able to eject a good ejection fraction or a good cardiac output. So the higher the afterload, the harder it is for the heart the harder it has to work. So the higher is the afterload, the harder it is for the heart has got to pump against, so that it can overcome that resistance in order to have a good cardiac output. I hope you get that. I don't want to use medical textbook definitions because we always get lost. I want you to give it like sort of like a practical, so that we can practical definition, so that you can understand it properly. So that's the afterload. So what drugs interfere with the afterload? It's your ACE inhibitors. ACE inhibitors. So ACE inhibitors, what they do is that they decrease, they vasodilate. So when they vasodilate, they decrease afterload. That's how they decrease afterload. Afterload and peripheral resistance, they're not very different. So when you think about afterload, think about a systemic resistance caused by vasoconstriction. So you give an ACE inhibitor to vasodilate so that you decrease the afterload. And if you decrease the afterload, the heart is going to be able to easily overcome the pressure that is there. It's going to be easy for the heart to pump against that. So remember, the higher the afterload, the harder it is for the harder the heart has got to pump. And we don't want the heart to pump hard. So use ACE inhibitors there. Another class of drugs that you also use there is your ARBs, angiotensin angiotensin receptor blockers, ARBs. Okay, let's give examples of drugs there. ACE inhibitors, most of the drugs that are antihypertensives and they end with the suffix pril, like pril, majority of them are ACE inhibitors. Examples are your captopril, enalapril, perindopril, lisinopril. So those drugs are ACE inhibitors, but the most commonly used that is available at our disposal at the government sector is enalapril. And then we've got ARBs. ARBs, like I said, are your angiotensin receptor blockers. These drugs have recently been used as well. They are not very common, but you will still find them. And majority of them, they end with the suffix Satan, S-A-R-T-A-N. So your Satan, your Satan. So those are your ARBs. Your ARBs. And then now moving on to heart rate. We know that decreasing heart rate decreases cardiac output and eventually blood pressure. So what are the drugs that can decrease heart rate? Beta blockers. Beta blockers. And remember, we've got three types of beta receptors: beta 1, beta 2, beta 3. Beta 1 is found in the cardiovascular system, like in the heart and in the arteries. And then beta 2 is found in the airways. So beta blockers can either be non-selective or selective or non-selective. So a selective beta blocker, it means that it only targets beta 1, and a non-selective beta blocker, it blocks both beta 1 and beta 2. And you don't want to block beta 2 on asthmatic patients with COPD, patients with bronchitis. I wouldn't want to block beta receptors on any patient who's got airway disease, no matter the type. Personally, I wouldn't want to do that. So it's better to avoid non-selective beta blockers on all those patients and go for specific ones. So there is the suffix. Most of the drugs that are antihypertensive and they've got a suffix lol, majority of them are beta blockers, like propranolol, atenolol, carvedilol. So the most commonly used one is carvedilol and atenolol. Carvedilol is a beautiful drug because research shows that it's very potent when it's used in heart failure. It's good for as an antihypertensive, but it's much more better as an anti-failure drug. So that's why cardiologists, they love this drug. If a cardiologist has got to choose a beta blocker, I can put I bet that they will use a carvedilol. They will use carvedilol. Yeah. So this is where we are. So the last thing now I need to talk about here is peripheral resistance. Peripheral resistance and afterload is not very different. Peripheral resistance is, if you've got a high pressure in the arteries, it's always going to be harder for the heart to pump against that. So things that can cause resistance in the arteries, it is anything that can narrow the lumen of the arteries. Conditions that are known to narrow the lumen of arteries, be it your aorta, whatever, conditions like arteriosclerosis, and atherosclerosis. Smoking is known to cause thickening of the arteries as well. This one is so arteriosclerosis is the fibrosis of the lumen. So the artery is no longer flexible anymore. It's just so rigid because of the fibrosis, and you get that with old age. As arteries age, that's what you get. And then atherosclerosis, it's plaques that plaques that become deposited intraluminally. So those, they narrow the vessels, meaning they cause some sort of a vasoconstriction in a way. So they narrow the lumen, and if you narrow the lumen, you increase peripheral resistance. So that's why it's important when you treat high blood pressure, you have to treat atherosclerosis. There isn't much that you can do about arteriosclerosis, but you can treat atherosclerosis with your anti-lipid drugs. That's why patients that are taking antihypertensives, at least every year they should be done a lipogram, because when you sometimes you might be using 4 drugs to treat a non-responding blood pressure, only to find out that you also have this now, an increase because of the atherosclerosis. So if you screen them for cholesterol, you might be able to start them on a statin before they can actually start to have uncontrolled blood pressure. Okay, so the drugs that you use there, yes, you still use your vasodilators. Try to vasodilate them as much as possible, even though you know that there might be a plaque that is blocking there, but you still give if they have when you do their blood, the blood results come out and then they have atherosclerosis, then you will also address that. Yeah, so these are your antihypertensive drugs. One drug that I'm also forgetting is hydrolyzing. Hydrolyzing is a vasodilator. So hydrolyzing, this drug is known, it's by the time a patient has got to use this drug, a non-pregnant patient, it means that blood pressure is very stubborn. It's not one of your drugs that you just use as you start. So let's talk about how do you use these drugs. Okay, I am going to talk about hypertension, how you diagnose it, maybe in one of my upcoming videos, but we'll see. So now let's say you have a patient, you are convinced that it's hypertension, you have done all the tests that rule out other secondary causes. Now we say, okay, this is hypertension. So now how do we go about it? So the first line drugs that we use, so you start with a thiazide. You start with a diuretic. Diuretic. That's what the guideline says. You start with diuretic, and the drug of choice is Reduc or HCTZ. HCTZ. And there are patients that are on indapamide, but that's mostly your private patients that are treated in the private sector. They are started on an indapamide, which is still fine because it's still a thiazide diuretic. So your first line would be your HCTZ. And then while I'm still at this, when you go to other places, majority of white patients, for some reason, they respond to ACE inhibitors as their first line. So don't be shocked when you find a patient who's only taking one drug and that drug happens to be an ACE. Studies have shown that they tolerate it better, and also their blood pressure responds better to it. So that's why they normally started there. So yeah, so let's say you use this, the patient, the blood pressure is still high. So your second line will be ACE inhibitors. Second line, ACE inhibitors. Drug of choice there is enalapril. That's what is widely used now. Previously, patients were put on Covacil or perindopril. That was the most common one. But I think the government now has, maybe because of other logistic problems or whatever, but now the most commonly used one is enalapril. Enalapril. So this is in the context of South Africa. So you use that. Let's say you use this and it doesn't help. Now you want to go to the third drug. When you get to the third drug, let's hope maybe it would be maybe after 10 years or after 20 years, this patient would have started a treatment, not immediately. So let's say now you want to consider a third drug. So the third drug, the third drug that you can use, you can go now to calcium channel blockers like your amlodipine, your carvedilol, your atenolol. That would be your third. As much as some people might say, okay, so diuretic, AC inhibitors, calcium channel blockers, and then when you get to, okay, this is what I want to talk about. That's why I'm so disturbed in my mind, because I know that I wanted to say something but I'm forgetting it. So let's talk about, because this thing is about if you have a patient that you want to give an AC inhibitor, you gave them HCT, but now you want to add an AC inhibitor. So one of the or two of the most common reasons why someone would be changed from an ACE to stop it and move to a calcium channel blocker or an ARB, it will be someone who's got angioedema, which is a side effect of ACE, or they are developing that cough that you get with ACE inhibitor, that chronic irritating dry cough that you get with ACE inhibitors. So if you can't use this, then the next drug of choice would be your ARBs, which are in the same class there, which are also working, like the target is the same. So you will use you can either switch to ARB or go to a calcium channel blocker, depending on what you want to do. Personally, I would go to an ARB. But if they are not tolerating it as well, because there are people who say that if a patient has angioedema on AC inhibitors, they might also have it with ARBs, or if they've got that cough with AC inhibitors, they might also have it with ARBs. So it depends, because not all patients are going to have it, so it depends. But if you change your patient to an ARB because of angioedema or because of the cough, then just keep it in mind that this patient might still have the same side effects. So just know that then you might have to move on to a calcium channel blocker. Yeah. So we know when to use this, and use this. And then usually beta blockers are your number 4. But then remember, guidelines change every time and people do different things. Some people might use a beta blocker even here as a third drug, as a third line. They might still use it. But just remember there's that. And then let's talk about side effects of antihypertensive treatment. So side effects, let me just get a space here. So what are the side effects of antihypertensives? Side effects. All antihypertensive drugs have got a potential to cause hypotension. Hypotension. Number 2, any drug that you take orally has got a potential to cause nausea and vomiting. Abdominal cramps or abdominal pains, and also diarrhea, because they might irritate the GI system. That's why you can have those. But now, if you're talking about specific drugs, loop diuretics are known to cause. Okay, loop and thiazide diuretics are known to cause hypokalemia. Unlike spironolactone or aldactone, because it's a potassium sparing, so it spares the potassium. So patients that are on that have got a risk of having hyperkalemia, unlike the other 2 diuretics, where patients have got a risk to have hypokalemia. Another thing with thiazide, another side effect of thiazide is erectile dysfunction. Not all patients are going to have it, but some have presented with it. Another side effect of a thiazide, patients that are on gouty arthritis medication, it's known to precipitate gout. So which means that if you've got a patient that keeps coming because of gouty arthritis and they are being compliant on medication and they are following your diet advice, but they still come back, then you might want to change to a different diuretic if they've got hypertension or heart failure. So that's that. Previously, patients that are on a loop diuretic were always given potassium supplements because of the hypokalemia that they are at risk of getting. New studies have shown that if a patient is on a loop diuretic and they are taking an ACE inhibitor, you don't have to give them a supplement. You can go and check these guidelines on EM guidelines. So if a patient is on a spironolactone, you don't have to give them supplement. If they are taking an ACE inhibitor, you don't have to give them a potassium supplement. And then side effects of calcium channel blockers, bradycardia, hypotension. Yes, allergic reactions can happen with anything that you take that you're not used to, that you're allergic to. And then side effects of ACE inhibitors. What is causing that irritating cough that these patients usually get? So when you remember, angiotensin converting enzyme is found in the lungs, and if you inhibit that enzyme using your ACE inhibitors, you allow a buildup of bradykinin, which is a cytokine, and that cytokine is the one that irritates the airways and causes the patient to cough and cough and cough and cough and cough. And these kind of patients, you can investigate them for years. You won't find a cause up until you just stop the ACE and move to the next drug. The angioedema is also very bad. Angioedema, they come in with a swollen lips, like massively swollen tongue. Some of them might even have difficulty with breathing because of the swelling that they're experiencing in the upper airway. So it's bad. Side effects of beta blockers, bradycardia as well. They can bradycardia because you are blocking their beta. Because for you to increase your heart rate, remember you need your catecholamines to come and bind to those receptors. So now if you block those receptors, it means now the catecholamines won't have a receptor to bind and increase the heart rate. So that's that. Yeah, I think that's it with antihypertensive drugs. I'm not sure if I'm missing something. If I am missing something, kindly comment and put whatever that I'm missing, or even corrections are welcome. If there's anything that you need clarity on, you can also put a comment there on YouTube, and then I'll look into it. Thank you so much. This is Dr. T, and I'm signing out. Bye, and bye.